Good morning, everyone. My name is Beka Bakhtadze. I'm PGY4 Fresh Fellow here with Reddy. It's my pleasure and privilege to be here in front of you. Dr. Klein, thank you for this opportunity. I would like to join and the congratulations of the recent success for the rest of the trial. Today, I'll be presenting the case that, as the name suggests, it's a somewhat unusual mix. And I had spent some time watching and seeing images of this patient just to understand what I'm looking at to start with, because it's a congenital case. And obviously, the mix of constrictive and restrictive cardiomyopathy and physiology, I think it's an interesting topic to discuss. Just to summarize what we are about to discuss, basically it's going to be brief discussion of what congenital abnormality we're dealing with, and I'm glad that Dr. Phillips is here. Also, we'll talk about physiology behind constriction and restriction, and also present one of the patient's course that I saw with Dr. Klein approximately 2 months ago. To proceed ahead and present the case, this is a 33-year-old male with a pretty complex post-medical history, as you can see, with congenitally corrected transposition of great arteries, also known as LTGA, congenital bicuspid aortic valve, status post AVR, and I'll give you the timeline of interventions in the next slide. Unfortunately, complicated with post-operative complete heart block requiring BiV pacemaker. Recent diagnosis of atrial tachycardia, was admitted to hospital, let's say 6 months before we saw the patient for sotalol induction, and has been remaining on sotalol. He basically came to Dr. Klein's clinic seeking further options about pericardial disease. This was as vague as it could get because we actually did not know what we were going into. Just to give you the timeline of the diagnosis and how patient actually ended up coming to the clinic in 2020, patient was born in 1987. Obviously, diagnosis was made at that time. He had bicuspid aortic valve, for which he actually underwent aortic valvotomy at the time. Also had aortic homograft done in 1989, so 2 years after birth and age. And after that, he had in 1992 AVR with number 121 St. Jude valve. Interestingly enough, he still has the same valve, and it's been functioning pretty well. Unfortunately, as you can see, timing here, after surgical intervention, he has gone into complete heart block and required pacemaker placement. History continues. So approximately for the last 12 months or so prior to presentation, and to give you the timeline, we saw the patient somewhere in October. Patient has been having multiple ER visits for shortness of breath, some isolated right upper quadrant pain, and this care has been delivered through multiple hospitals between UPMC and CCF. Basically, all hospitals on the way had seen this patient. He has had undergone multiple evaluations for right upper quadrant pain, right chest pain, and I'll give you the timeline of what studies have been done so far. First time we have any documentation of patient getting evaluation here was in June of 2020, where he had actually pediatric catheterization of the left and right heart cath. Interestingly enough, he has also undergone liver biopsy at the time. Again, I understand the reason behind it was this right upper quadrant pain. He had some transient elevation of liver function tests. In July, he had pediatric TEE. One of the CT studies he had done here at our clinic was during this visit because of the shortness of breath, chest pain, and he had formal TT at the time of our visit in the clinic. Just to briefly refresh our memories about what CCTGA stands for. For me, the easiest way to remember is everything is exactly the same. It's just LB and RV sites are switched. Meaning, just to describe briefly, on your left, you are seeing normal physiology, obviously normal anatomy. Onto your right, you are seeing that RA is draining in morphologic LV, and LV here serves as subpulmonic ventricle, and then obviously it delivers blood to the PA system. Similar change on the left side. You are looking at left atrium, draining blood in systemic ventricle, which is morphologic right. Morphologic right, systemic ventricle is draining blood towards aorta. You can see that one of the key findings here, atrioventricular valves belong to the morphologic ventricles. Technically speaking, this valve between LA and systemic ventricle is tricuspid valve. Also, technically speaking, the valve between right atrium and morphologic left is mitral valve. So not to complicate things, I will be referring to these ventricles as systemic which would be morphologic right. I will be referring to right-sided ventricle as subpulmonic, which is morphologic left. To proceed further, I saw so many cath films, and it took me, 3-4 days to understand what I was looking at, and after asking lots of people. So I think these are probably the most interesting cath films to discuss. Onto your left, you are seeing, this is patient's sternum, so this is the LAO view. Here you are seeing that, I was actually showing this ruddy yesterday, and first impression, if you had to guess, this is non-compaction cardiomyopathy, because you see significant trabeculations of the ventricle here. Well, obviously, this is not non-compaction cardiomyopathy. Considering patient's history, this is morphologic right ventricle, which serves as the systemic ventricle, basically pushing blood towards the aorta. A couple subtle findings that, had I not read the very, very detailed report, I probably would not pick up on it, are the following. You can see at the end, there is some regurgitation towards the left atrium here. If you pay attention, you will see that contrast is also going towards the left atrium, which is suggestive of, at this moment, AV valve regurgitation. You can see patent flow towards the aorta. According to the report, and I think you also have to pay good attention, there is some regurgitation back from the aortic valve to the systemic right ventricle. And towards your right, you are seeing morphologic left, but subpulmonic ventricle, which is delivering blood towards the pulmonary system, which is somewhat dilated, as you can appreciate, and similar findings of technically AV valve regurgitation, because you are also able to appreciate some amount of contrast regurgitating back to the right atrium. I thought this was interesting. Of note, patient also had pretty significant findings of other congenital abnormalities here. I don't have the images, but his LCX artery left circumflex is technically originating from his right cusp. Luckily enough, I was able to track down the hemodynamic findings during that pediatric authorization that he had. So just to give you and reorient you exactly what we are looking at and not to confuse with terminology, here you are looking at obviously EKG so that we know where we are. The red line here, and this is tracing, is here from right femoral artery. So where femoral sheath is in, and we're just transducing the pressure. Here, with the blue tracing here, we are seeing array pressure. A couple things to underline here. These are X and Y descents, which are very typical findings for constrictive physiology with sharp X and Y descents itself. Interestingly enough, on next slide, we have somewhat more information. Again, to go through basic things, we're looking at the EKG on top. We are looking at, again, ascending aortic pressure tracing. We are looking at, with this, yellow tracing, we are looking at RV. Again, this is systemic ventricle. And then we are looking at left atrium here. Without further ado, you can recognize our square root sign here, which I think was one of the cool findings on this hemodynamic tracing. One other thing you can also notice, there is obviously the gradient between systemic ventricle and the aorta itself, which is correlating probably somewhere around 10 to 15 of the gradient itself. And this is consistent with our echocardiographic findings as well. I think these are some two small details which suggestive and sort of confirmatory for the constricted type of physiology for this patient. Moving onwards, this is the summary of hemodynamic findings. I'm not going to go through all the details, but just pay attention to diastolic numbers. And technically, we can qualify this equalization of the diastolic pressures in almost all chambers, which again, significant finding, etiologic factor for the constrictive physiology itself. This patient, interestingly enough, as I said, has undergone liver biopsy. And liver biopsy results here, just to not overwhelm you with details of pathology results, are pretty consistent with sinusoidal dilation, some extravasation of the RBC, but otherwise normal hepatic structure. This is typical finding of a hepatopathy and hepatic congestion in any reasons that one may have right atrial pressure elevation. As I mentioned, patient had complete heart block and his pacemaker dependent. Thus, we unfortunately do not have any MRI findings, but we have CT findings here, which is, if you pay attention, I'm going to try to find the appropriate slide. Somewhere here, if you pay attention, There's a small isolated locule, sort of a loculated pleural effusion that is tracing all the way from sort of vertically and follows the AV groove. You see that the almost visceral part of that sort of pericardium is pretty significantly calcified, which is also clinical finding of potential constrictive pericarditis. I'm going to try to show you this view. I tried to find that here. I don't think that fluid collection is pronounced very well, but just to repeat one more time, on this CT, I think it's pretty impressive, this loculated pericardial effusion just sitting there as per CT and radiology's description, causing some mass effect towards the AV groove and the right-sided system. To move forward, this is the patient's parasternal long axis view. As you see, you can appreciate the trabeculations. As a reminder, we are looking at morphologic right ventricle, which serves as the systemic ventricle. Technically, this valve here is tricuspid valve, morphologically speaking, aortic valve here, and LVOT, I should say. There are some calcifications, possibly because of the attenuation of the signal from the posterior wall here. Somewhat decreased. Estimated EF here was about 45 to 50%. I'm going to go to apical four-chamber views. As a reminder, again, here to the left side of the image, you are looking at systemic ventricle, which is morphologic right. You're looking at left atrium. We're looking at right atrium, morphologic left ventricle, which is subpulmonic ventricle. Couple things to underline here. If you pay attention, there is a significant signal attenuation at the side of the left ventricle, morphologic or left ventricle, and the right atrium. And there is some tethering. So also, we will talk about something called annulus reversus later, but I think it's appreciable here if you pay attention to the medial side of, say, normally what would be a mitral valve, is bouncing more than actually the lateral side. And also, if you pay close attention, something that Dr. Klein uses in any other sentence, septal bounce. You can also appreciate that. Also, to put some perspective here, patient also has findings of mild tricuspid regurgitation on the right side, on the Doppler, which also corresponds with the RV gram findings as we saw on previous slides. Moving on, this is the contrast injected to the patient's system. I think this is probably the best view, and I think one of the best echo findings we could see. This is the septal bounce, yet again pronounced pretty clearly if you pay good attention. Moving onwards, obviously hemodynamic findings. So just to reorient you one more time, we are looking at inflow pattern of the systemic ventricle itself, which is morphologic right ventricle. And I didn't want to name the valve itself, just I'll go with atrioventricular valve inflow variability. Interestingly enough, our measurements of systemic ventricle as well as subpulmonic ventricle AV valve did not show findings consistent with constrictive physiology. That's when things got interested, because the rest of the things I already talked about are pointing clearly towards the constriction and constriction type of physiology. Also, I want to underline that during catheterization, I must have probably underlined that LVEDP was significantly high, which also suggested presence of restrictive physiology. A couple other things to mention about the restrictive physiology as well is that the presence of tricuspid regurgitation and some decreased relaxation pattern of the ventricles also are consistent with the restrictive physiology. So this is the case where we're going back and forth. Is this restriction or constriction, or is this both? And as the name of my presentation suggested, this, unfortunately for this patient, is consistent with both of the cardiomyopathies. Moving forward, this is annular tissue Doppler velocities. On to your left, you are seeing the medium annulus, and on to your right, you are seeing the lateral annulus. I'm not going to go into details, but clearly you can see that medial annulus is moving faster and longer, I should say, compared to the right. This is something called annulus reversus, which should be the opposite in the normal cardiac physiology, which is also a characteristic finding of constrictive physiology. This is the annular tissue Doppler velocity obtained from what it would be lateral tricuspid annulus in normal physiological heart, and you can see significantly decreased function. Again, suggestive and supporting diagnosis of restrictive physiology here. Obviously, the next pictures would be consistent with actually pretty normal diameter of IVC, no significant dilation, and actually it's more than 50% respiratory variation and collapsibility. This was very interesting hepatic vein Doppler findings, which we could not really pinpoint exactly if this is also suggestive of constrictive physiology. And we really tried, but this particular hepatic vein Doppler findings, we're not finding the typical diastolic expiratory flow reversal, which unfortunately during this echocardiography we were not able to catch. So again, I'm trying to send messages that there are several findings that suggest restriction. There are several findings that suggest constriction, and this was sort of diagnostic dilemma to what category should the patient belong to. Moving forward, obviously, who but Dr. Klein had described this findings in actually 38 patients here at Claremont Clinic. Just one thing, just to, for sake of time, to go through, we isolated and found 38 patients who had features on both mixed constrictive and restrictive physiology. Here you can see basically inclusion criteria to quantify and qualify these patients for both mixed physiology. Just the most important finding during this study was that clinical outcome is unfortunately significantly worse in patients who have both findings of mixed constriction and restriction, as opposed to just poor constriction physiology cardiomyopathy. And these patients were followed approximately 5 years, and unfortunately, as you can see, the survival rate is significantly lower in patients who have mixed physiology. The clinical implications of this particular case is, I think every time I thought about constriction and restriction, the question always is, how do I differentiate between those two? Up until seeing this case, I actually did not even know that patients could have both at once. And I really appreciate it, and obviously going through the hemodynamic findings and echo findings make more sense now. The clinical implication here is, for patients' perspective, I think it's better to know which category do these patients belong to, because if I had to choose, obviously, as you saw the data, I would rather have just constriction cardiomyopathy rather than both. This patient's course was actually interesting because we did not necessarily feel that patient had some clinically decompensated heart failure symptoms. As you already saw sort of in the clinical presentation, you saw the IVC. So we actually recommended just establishing here with the congenital cardiology here, CT surgery as needed, and potentially consider whenever time comes for his aortic valve to be replaced, at that time addressing the loculated pericardial effusion. Conclusion-wise, as I said, several etiologies of cardiomyopathy can coexist, and as you saw, this is the typical case of both constriction and restriction existing together. I cannot underline the fact how important it is to have multimodality imaging, and unfortunately, as I said, we did not have the MRI with this patient, but I think we had enough findings to support diagnosis of both physiological findings. I think I have a couple more minutes, but I think all the fellows who are on call, or like even residents or med students, these are very two good educative sort of animations to differentiate and understand what is the respiratory phasic variation of the right ventricle and what is this septal bounce all about. And onto your right, you can, I'm going to try to play the video. Yeah, you can see the difference between normal physiology of the heart, and basically here we're concentrating on the medial annular movement, and also you can see during restriction physiology, restriction cardiomyopathy, this is significantly decreased. On the contrary, as we saw the square root sign on the hemodynamic findings on this patient, you can see that in the horizontal plane, in the constrictive pericarditis, the horizontal plane is almost stuck. So the heart muscle is not actually moving toward in the horizontal plane. Just to play it one more time, you can clearly see that the heart is sort of bouncing back and forth in the vertical plane. And that's why we see this rapid movement of mitral annulus here and rapid emptying of the right atrium towards the, left atrium towards the LV. Thank you very much for the opportunity. And I hope you enjoyed.
Thanks, Beka. That was fascinating. Your congenital restriction, constriction, and when do we do surgery? Now, Alistair, you saw you did a distance health visit with this gentleman. From the surgical aspects, when you see a case like this, do you wait? Do you rush to surgery? He has an old valve. He has some of the a lot of constrictive features. Or do you pause and you say, let's see how this is going to go?
So, again, this is why it's important to have a multidisciplinary team. And, I think one of the benefits of Cleveland Clinic, it's having all of the pieces in place so that you can make the right decisions. And in this, the other key aspect is it's a corrected transposition, and the RV systolic function is slightly diminished. So you have, I believe he had an RV, which is the systemic ventricle, of 40% was the EF. And so ultimately you have to look back at time, and I thought the title was very appropriate. It's what decisions are you making after birth and through that time. So he had pulmonary valvotomy, then he had an aortic homograft, and one of the issues that you see is he's got a lot of calcification around his aorta, which is going to make it very difficult then to go back in. I think he has a 21 St. Jude valve, which is probably small for him. However, his issue is it's then you have to worry about RV function and sustainability. But going back, I think what we would do differently here at Cleveland Clinic is we would actually set this patient up to have a double switch. And that would be, then you would be leaving him with his aortic valve would be his pulmonic valve, which is much easier then to deal with in the future. And I think we're very fortunate we have Dr. Najim in the room, and who's been leading a lot of these work to changing the ventriculotomy, and I think his comments would be good. But ultimately for this patient, he's a complex heart failure patient, and the route that we're looking at is probably a heart transplant for him down the future, looking at better long-term, where you would have to take all of that out.
Dr. Najim, any comments on this? You see this, both of you see these cases all the time. Any suggestions on a case like this?
Fascinating case and interesting physiology, I have to say. And it's also really puts a twist on the diagnosis and what we need to do next. And I agree with Alistair. We would have set him on a different track if he was seen here at the clinic. Having said that, we have this patient with compounding factors, I would say. First of all, he's got a systemic RV. 2, he's a long-standing pacing, which will impact obviously the myocardial function. 3, he's had 2 or 3 sternotomies, and he's got a thickened fibrotic, probably myocardium. All these factors, the presence of TR is something that we see in a systemic RV, failure late in CCTGA. All these factors compound. And to me, I'm just thinking as you were presenting this case, is there any way that we could know what is impacting one more than the other? As in, is the restriction is worse for his symptoms, or is it the constriction is worse for his symptoms, or is it just a pacemaker, late pacemaker, cardiomyopathy that is because of all those long. So I don't know if we are able to ever tease these out from the outlook, but these are very important questions, and obviously will determine what we do next with a patient like this, because what you want to do in somebody who's got all these complications is to make sure that you do the right thing, you get him better. Otherwise, you're going to be in a more difficult situation when you expose the others and you're not doing the right thing. I don't know if you, Alistair or Allan, have any insights on what you think is more, and if there are experience in post-cardiotomy, pure constrictive pericarditis, is there a mileage in doing a pericardiotomy when we know that the pericardium is open, but it's thickened?
I think that's the trick on this patient. Is I think ultimately it's the redo. It would be his 4th operation, and then he has the pacing wires that are connected around his heart, which is causing some of the problem. Then he has the myocardial issues, and so it's, again, ultimately to me, there's so many confounding issues, and then what is going to give him the best long-term survivability, and that's where we, got the benefit of having a great heart failure team here to come in and hopefully weigh in on that, and that's where we're looking at right now.
No, those are great points. And fortunately, when we saw him, his symptoms weren't that bad. He was pretty active and actually had some pain on the right side. But so Debbie, when we get referred these patients, for constriction, for pericardiectomy, I would say 10-20% of the time we find right-sided dysfunction, systolic dysfunction, and TR. So, they'll have JVD, they'll have some ascites, right heart failure, and they sort of look the same. And as an imager, any thoughts about how to look at some of these things, the TR, the RV dysfunction, the constriction, sometimes very difficult?
Yeah, definitely. I think this highlights the complexity of these cases, especially when there's a mixed picture going on. I think the strength of cardiac MRI also is that it provides gold standard assessment of the RV. So, by echo, we see it pretty well, but with the cardiac MRI, we can actually provide ejection fraction of the RV. And then with the tissue characterization, there can sometimes be characteristic delayed enhancement patterns that can help you identify RV cardiomyopathies, or if there's significant pulmonary hypertension that's causing RV dysfunction, that can also result in some characteristic tissue characterization by cardiac MR. But it can still be very challenging because you can still have the respiriphasic flattening of the septum with RV overload, which can sometimes mimic constriction. And some of these patients have both, so it can be very challenging for sure. One of the things that Doug Johnston is starting to do in these patients who are going for pericardectomy is to actually take a myocardial biopsy so that we can understand that patients who have a myopathic process, can we start to identify imaging signals and features on cardiac MR and maybe also with echo prior to these patients going to surgery. And hopefully, with all these techniques with AI and radiomics, we can maybe get a little bit better from the imaging perspective.
Becca, a quick question. That was terrific going over constriction and restriction. So there was an old joke at Cleveland Clinic. When we didn't understand, we called it the mixed bag. And here we are, the mixed bag. So here you had, I remember you in the clinic, the next case to look at, and you started looking, this is a congenital case, a corrective transposition, constriction, restriction, pacemaker, AVR. And you took a big breath and he says, any thoughts in preparing for this case, learning from this case for the other fellows? Any suggestions?
Yeah, so I think it's like one textbook of cardiology in this patient, including almost everything, hemodynamics, anatomy, embryology, you name it. As I said, honestly, I looked through echo, I looked through angiographic findings so many times just for me to internalize exactly what I am trying to look at and identify the structures. As far as case complexity goes, every new patient who walks in Dr. Klein's clinic, many of you probably know there's a stack of papers that comes the patient first. And I think identifying the right information, what is the actual issue, because these people have been through 10 different hospitals at the time they get here. And identifying exactly what the problem is, identifying what can you actually offer, what are the new studies you want to redo, and so forth. This is one of the key things to learn to navigate through this complex referral center such as we are here.
Okay, Dr. Grimm, any thoughts about this complex case?
Yeah, I think it's a fascinating case, and I think Dr. Najm hit the nail on the head when he brought up the issues. Clearly a multitude of issues going on. It's not surprising, really, I would say, in retrospect, that there is a mixed physiology with the restriction and constriction in this case. It's a relatively localized constrictive process. First of all, adjacent to that RV, the impact of pacing is we often underestimate that impact on both systolic and diastolic function, and I think it's clearly at play here. In fact, the physiology, I think, although you didn't see a prominent reversal in the hepatic veins, clearly there was a dramatic Y descent present in this particular case. And it seems like certainly ultimately the right thing was done, and the patient wasn't doing too badly. doing reasonably well. Clearly, it would take a significant operation to address this, not minor with all the prior surgeries. Precisely, I think it made reasonable sense in retrospect, and clearly the right approach was taken, I'd say. And certainly, if you ever need something in the future, clearly the team's here to be able to make that happen as well. So, great case.
Yeah, that's the beauty of the team of teams. But on that note, I want to thank the presenters and the panelists for discussants for excellent case presentations. Thank you very much.